go for hemostasis. That means there is a massive blood loss that you have to replace. Then second point which is important is the management, treatment. So the treatment in from 0 to 5 years of age, it is treated by hip spica. All right. Now, as you can very clearly see, just in this image itself, that hip spica is the enclosure of the half of the trunk inside the cast so as to immobilize the pelvic bone. Then the entire shaft of femur which is broken, and the ankle is rendered free. All right. In this case, there is a bilateral fracture of the femur. But in case of a unilateral, the other end of the thigh is also enclosed so that you have to limit the movement of the pelvis. When you limit the movement of the pelvis on this side, then the possibility of this movement would be transmitted on the affected side also. And if there is no, or if there is a permissible movement at the fracture side, it might go into complicated unions. All right. So in order to achieve the perfect immobilization, the half of the trunk or the pelvis is immobilized, then the other thigh is immobilized, and the entire lower limb is immobilized by keeping the ankle joint free. This is hip spica conservative mode. Now, for the children who are beyond 5 years of age, like 5 to 12 years of age, 5 to 13 years of age, where the epiphysis is not yet fused, you have to go for, so 5 to 12 years of age, you can go with the placement of TENS. That means transcutaneous, this transcutaneous nail insertions, or you can go for the K wires. All right. So intramedullary wires, basically what you have to remember is the placement of intramedullary wires, where perfect immobilization is not required. You just have to keep the ends of the fractured bones aligned, and it will heal automatically because the age of the child is less. But when there is a complete fusion of the joint, and in case of adults in particular, how you will manage this condition is closed reduction or open reduction. If at all required, you can go for open reduction also. And intramedullary nail fixation. All right. So nail, how is it distinguished? The nail is distinguished from the K wire intramedullary because in case of nail, there will be a fixation by the proximal and the distal screws. So proximal and distal screw fixation, 3-point fixation is required in case of intramedullary nail. And wire is simply the placement of the wire to keep the two edges of the bone aligned to each other. All right. So this is how the management is achieved. Now, one more thing is important with the fracture shaft of femur is that imagine if the fracture shaft of femur is neglected, then these two bones there is a possibility of massive overriding. And this massive overriding can lead to a maximum shortening of the limb. You know, maximum shortening because of any fracture can happen because of fracture shaft of femur. All right. So neglected fracture shaft of femur, by putting a star, you can write it down, that neglected fracture shaft of femur results in, or can result in, maximum shortening of the limb. Just try to understand. Means, or just imagine there is no other fracture that can have this massive overriding. All right. If there is a fracture in the shaft, then we can have the maximum possible overriding of the fracture fragments, leading to the massive shortening of the lower limb. All right. So this much you need to remember about the fracture shaft of femur. Only 3 points. Point number 1, the blood loss. Point number 2, the management based on the age groups. And point number 3, that it is a kind of a fracture which will have the maximum shortening if it is neglected, if it is not treated. Then comes the important topic, that is patella fracture. Now, you know, all of you are aware that patella is the largest sesamoid bone of the human body, and there is a possibility of the breakdown of this bone also. But you know, patella fracture related topic is important for 2 reasons. One is that what is the mechanism which is responsible for causing this injury. All right. So the topic is patella fractures or the fractures of the patella. Now, fractures of the patella can be broadly classified, although there are multiple other different types of the patella fracture that we can discuss. But as far as your examinations are concerned, you need to restrict yourself in identifying the 2 possible different types of the patella fracture. One is a transverse fracture and the other one is comminuted fracture. Now it is not very difficult to identify. Transverse means if this is the patellar bone, it is broken into two pieces like this. It will be a transverse type of the fracture. Comminuted fracture when it is broken into multiple pieces. And already in the introductory part itself we have talked about that the mechanism which is responsible for causing the transverse fracture usually is the extensive muscular contraction. Muscular contraction. And the name of the muscle which is directly inclined or directly arranged or directly related to the patella is the quadriceps. So if there is a massive contraction of the quadriceps, it can break the patella into two. All right, muscular contraction, that is quadriceps contraction. So it is a indirect mode of injury. It is not the direct blow. It is not the direct trauma to the knee joint. While comminuted fracture mechanism is always the result of a direct trauma. All right, direct mode of injury. Now, as far as the treatment of these two types of fractures are concerned, so if we talk about the management protocol or the treatment protocol for the patella fracture, which is transverse fracture, so treatment can be divided into two. One is for undisplaced fracture. You know, if the fracture fragments are not displaced at all, that means there is no separation in between the fracture fragment at all. So it can be managed conservatively also. So conservative management by cylindrical, also known by the name of tube cast. All right, cylindrical cast or the tube cast. Imagine if the fracture is there, but it is not completely displaced. There is no displacement at all. And the two fragments are attrited to each other. They are still in contact to each other because there is no associated injury to the muscle fibers. So it can be managed conservatively. And that conservative management will be based on the cylindrical cast application or tube cast application. Now, this is how the cylindrical cast looks like. Now, 2 points how to identify a cylindrical cast. Point number 1, the knee is kept in extension. There will be an extension in the knee joint. All right, knee is not kept in slight amount of flexion because whenever you apply a long leg cast in the lower limb, the knee has to be kept in 15 degrees of flexion. Here it will be kept in extension. Point number 2, ankle is kept free. Means there is no enclosure of the ankle joint inside the cast. It is only from mid-thigh to up to the 5 centimeters above the level of medial malleolus. So that is how cylindrical cast is applied. All right. Then comes the displaced fracture. Imagine if the fracture is displaced. If the fracture is displaced, the fragments are displaced from each other, then in that case, it is managed by tension band wiring. All right. Now we are going to have a discussion on this tension band wiring after some duration of time. Before that, we will talk about the management or the treatment of comminuted fractures in the patella. Now, same, if the fractures are undisplaced, that means comminuted fracture is there, but there is no such displacement, then it can be treated in a same cylindrical cast. But if the fracture fragments are displaced from each other, then it has to be treated by encerclage. So let's have a discussion on what the encerclage is. Encerclage simply means that imagine if this is a patellar bone which is broken into multiple pieces. What you do, you put two SS wires, the two stainless steel wires of 18-16 based upon the size of the bone. You put the two SS wires and then fix at one end parallel to each other. That means anterior and posterior, thereby holding all the fragments together. And then you enclose the entire limb inside the cylindrical cast. You wait for the duration of 6.5 or 6 weeks. After that, you can remove the cast. You will ask the patient to bend the knee joint. Once the knee is bent, when the patient is bearing weight and there are no problems related to the fracture overall, then you will remove the wires also. So this way, you have saved the patella, because patella is an important bone for the biomechanics, normal biomechanics of the knee joint. All right. Previously, what they used to say that if the patella is broken into multiple pieces, perform patelectomy. That means remove the patella. No, patelectomy should never be performed. Majority of the time, the patella should be preserved as the management protocol. All right, whether it is broken into multiple pieces or into simple 2 pieces. Now, let's have a discussion on the tension band wiring. Now, as far as this topic TBW or the tension band wiring is concerned, let's have a discussion. Point number 1, that what is the principle of tension band wiring? You know, there is a difference in between the principle and the mechanism. The principle of tension band wiring is to convert distraction into compression. That means to convert tensile forces into compressive forces. That is the principle. While what is the action? The mechanism of tension bend wiring is different. The action is compression at the fracture site. Simple. Compression at fracture site. Alright, now let's have a discussion on how this compression is achieved at the site of the fracture. Now, let's just try to imagine how the fractures of the patella might happen. Imagine this is the distal end of the femur and this is the proximal end of the tibia and this is the lateral view, alright, of the knee joint. And here we are having the broken fragment of the patella like this. Displaced transverse fractures of the patella. Now, what you do in tension bend wiring, just by looking at this image, what you try to understand over here, that you are inserting two K wires which are parallel to each other across the fragment, and after the placement of these two, you put a SS wire in a figure of 8 pattern holding the two fractures, holding the two fragments, and then at one end you try to tighten it up. When you try to tighten it up at one end, the SS wires, then both these two fragments are going to be compressed against each other. This is all the tension bend wiring procedure is. But what is the principle of the tension bend wiring and how is it responsible for achieving the union at the fracture site? This is what you need to understand. Now, what we do in TBW, there is a placement of K wires across the fracture fragment. The question is that where to put these two K wires? That means nearer to the anterior cortex or nearer to the posterior cortex. That means you have to put the two K wires parallel to each other, nearer to the anterior or the posterior or exactly in the center or in the middle. And how? The placement, different placements is going to have the different outcome. So for that you need to understand this distal end of the femur, proximal end of the tibia, and this is the weight bearing axis. This is the weight bearing axis. That means it is the posterior cortex of the patella which is nearer to the weight bearing axis. Any cortex of any bone which is nearer to the weight bearing axis is inherently under compression, and exactly opposite cortex of the same bone, imagine if this end of the bone is under compression, then the exactly opposite cortex of the same bone inherently will be under distraction. That means tensility. Alright. Now imagine if you put the two K wires parallel to each other near to the posterior cortex like this, alright, nearer to the posterior cortex, and then you put a SS wire and tighten it up and the two fragments are attrited against each other. That means by bringing the two fragments closer to each other, you are adding more compression on already compressive cortex. As a result of which, what will happen? There will be increased distraction at the already distracted cortex. So this is kind of a placement of the two K wires will fail. But on the other hand, if you place the two K wires, nearer to the anterior cortex, alright, like this, nearer to the anterior cortex, then and bring them together by SS compression, then the posterior cortex which is already compressive, there will be a compression. But anteriorly what you are doing, you are converting a tensile force, that means the distractive force, into compression. And now we are going to have a compression right from the anterior to the posterior cortex, and this is the kind of the placement of the wire which will have the best possible outcome. So this is what the principle of the TBW is. So what is the principle? It is to convert the distractive forces or the tensile forces into compressive forces. That is the principle. And what is the action? The action is compression at the site of the fracture. So this is all what you need to know about TBW or the tension bend wiring. As I told you, the indications of TBW, that means what are the other fractures where you can go ahead with the tension bend wiring, which could be treated with the tension bend wiring. Actually, any fracture where the concept of conversion of tensile into compressive forces could be utilized, TBW can be used for the management of those fractures. So giving you some examples like fracture of the greater tuberosity in humerus,